All right, with that introduction and with our discussions that's already been started, I want to more formally introduce Monica Vablea, who is the Professor of Anesthesia and Pediatrics at the University of Washington and Director of the Harborview Injury Prevention and Research Center. And as Dr. Adelson alluded to, is really an expert in kind of managing these kids and helping us understand how to do it in a consistent way. So with that, Monica.
Thank you very much. I really appreciate the opportunity to spend this time learning from the other speakers and also engaging in this conversation, because I think, there are folks from so many different disciplines for whom this topic is so very relevant. And so I appreciate that. So what I want to do is take a little bit of a different approach to talking about the care of severely head injured children. And I would like to use the PEGASUS Project as a framework for doing that. All right, so, one of the challenges that we faced in the care of children with TBI is that a lot of work has historically been done in what I call this bricks and mortar kind of framework, these silos, thinking about basic science, trying to figure out, what's the physiological abnormalities using animal models. Only recently has, I think, the community started to think about evidence-based care, somewhere bridging the T through to T3 block, and whether or not these clinical care interventions are actually effective, are efficacious, are effective, and whether they can improve population health. And I think that's the way all health systems are moving these days, is to really push us to think about outcomes, and not just survival, but meaningful functional outcomes. So the PEGASUS Project really stands for the Pediatric Guideline, Adherence, and Outcomes Project. And what we did here was to leverage implementation science frameworks to try to understand whether the guidelines actually work. There seems to have been so much variability in guideline adoption, in the use of ICP monitoring, whether or not advanced neuromonitors are used, how hemodynamics were managed, that we thought it was time to actually test whether or not the guidelines worked. The guidelines first came out in 2003, 18 chapters, and Dave Adelson was instrumental in that activity. And there were 18 chapters, no standards, no level 1 evidence, a lot of guidelines and options for care, because the data just didn't support that elevating the recommendations to that level. In 2012, 13 of those 18 chapters were retained. Some topics were dropped, some were added. The levels of evidence were retained in 8 and changed in 5, suggesting that there was a lot more work being done in this area, and this is really good. But the fact remained that the adherence to these guidelines remained unknown. The impact of adopting these guidelines was unclear. There was no class 1 evidence for anything. And then it was really not sure, how do you use these guidelines? There are, hundreds of pages of documents and tables and recommendations. How do you actually implement what is written in text? And I think these guidelines are really important because, as we've mentioned before, it addresses a very large public health problem for children, where there are large knowledge gaps, yet modifiable risk factors, and clinically relevant for pre-hospital providers, emergency medicine docs, surgeons, anesthesiologists, critical care physicians. And it's a large cost of about $6 billion for children and over $80 billion for adults. So this was a study that we did in 2008, where we examined the effect of the 2003 guidelines on ventilation strategies before and after. And we thought, we know it takes a little bit of time for guideline information to translate, right? 17 years typically. But we wanted to look and see, well, let's take a process measure and say, how long does it actually take for us to obtain a first CO2 sample at our level 1 trauma center? And we're a mixed adult and pediatric trauma center. And so we had 375 kids in the pre-BTF category, 89 in the post. And we could see that we actually had made some improvements. It didn't reach statistical significance, but we had large variability. And I think this is because it's hard to get vascular, get samples in kids. Sometimes people don't do it because they don't know what to do with the data. And I think all of this was problematic. But where I really found that we were still struggling was I think we all agreed by this time in 2008 that we shouldn't be aggressively hyperventilating children unless there was signs of impending herniation. And yet, about 50% of the kids at our center were still being aggressively hyperventilated when there was no suspicion of herniation. Equally concerning is the fact that ICP monitoring appears to be less frequent in infants because we think, and this is a controversial topic, that children who are, or infants have open fontanelles, many of whom are victims of child abuse, and they don't need it. And so we don't do it as a country. And in fact, when you look at how often ICP monitoring is done in pediatric-only trauma centers versus trauma centers that have an adult component, the pediatric-only trauma centers actually have less ICP monitoring than if the kids are being taken care of at an adult center. And I think this is because adult neurosurgeons are more familiar with ICP monitoring. I shouldn't say this to a bunch of neurosurgeons, but I think they use it more often, and that's borne out in the literature. Now, all of this variation is concerning because we do see variation in 30-day mortality rates by facility. And if you look at kids who have been cared for in the West Coast versus the Midwest versus the South versus the Northeast, there's clearly a risk ratio suggesting that the Northeast outcomes, at least in terms of mortality, are doing better. And I don't have any reason to really believe that the kids are less severely injured in the Northeast than they are in other parts of the country. And then came a really important paper in Lancet Neurology in 2013 showing that if you implement a pediatric neurocritical care program, you actually facilitate guideline adherence. And the process measure here that was used was the probability of ICP monitoring, which you can see on the y-axis, is actually higher after implementation of a pediatric neurocritical care program. This was a study that was done at WashU in St. Louis. So the conceptual framework for this project, which is now ended, is really to look at the organizational and provider factors that can contribute to adhering to pediatric guidelines, which we think actually will lead to better patient outcomes. But a lot of people don't believe that these guidelines work. And so we wanted to understand, is there actually a relationship? What are the barriers to adherence to adopting these guidelines? And can we develop some care pathways to improve guideline adherence? So our task number one was to look at the first P in the PEGASUS project, which is the protocols. So we wanted to look at the association between TBI guideline adherence and outcomes. Do the guidelines really work? Because everything in there is class 2 or class 3. Our inclusion criteria were age under 18, receiving care at a pediatric trauma center, and really having severe TBI. And we included patients with extracranial injuries because the reality is that at many of our centers, polytrauma is the norm, and we don't really have a large percentage of isolated TBI cases. Now, we stipulated that these kids should be tracheally intubated for greater than or equal to 48 hours in the ICU because if we included a lot of early deaths, we would never give chance for the intervention here, which is guideline adherence, to take place. This is a complicated slide, but I just want to tell you that we looked at this not just in the ICU, but pre-hospital, ED, OR, and ICU, and used clinically relevant indicators. So we didn't test nutrition in the pre-hospital, ED, or OR, but we tested hypoxia and hypotension in all of these sites. And we had 5 centers, and overall, out of the 236 patients, our guideline adherence rate at these leading trauma centers happened to be about 73%. But there was a large variation here, anywhere from 69. And then if you look at the different locations, guideline adherence really, varied equally between the trauma centers across all treatment locations. But this is important because it then allowed us to benchmark what we were going to be studying. That's our center at Harborview. We clearly were struggling in some areas and not in others. And we thought, well, let's look at our mixed model adult pediatric trauma center and look at our mortality rates. And in fact, across all treatment locations, that's the range, and the mortality rates did not vary. Now, so the first task we had was to look at guideline adherence and outcomes. And what we found was that when we pooled our data, for every 1% increase in guideline adherence, there was a 6% lower inpatient mortality. And these data were adjusted for injury severity, age, a whole host of other factors. And I can't completely say that we don't have any injury severity confounding, but there really does seem to be an association between adhering to the best evidence and improved discharge survival, and in fact also suggesting that discharge GOS has also helped. There also seems to be a dose effect. So you can adhere a little bit or you can adhere a lot. And if you look at these data here, as your guideline adherence rate improves, your mortality goes down. And these were seriously significant, right? You're looking at hazard ratios that are 0.2, 0.6, and 0.4. And these were, again, adjusted for age and injury severity. So is there a dose effect? I'm not sure. Probably there is. Is there a threshold effect? My guess is that, if we go back to that previous slide, you're really seeing a lot of benefit between doing something really well and then doing something very, very well where you see the biggest drops. So what are the things we're supposed to do? The guidelines have a whole litany of items, and I can tell you, as an acute care physician, it's very hard to do all 18 things at the same time. So we then wanted to make this very clinically useful and ask the question, what are the main drivers? Well, the main drivers seem to be early recognition and correction of pre-hospital hypoxia. So those of us who work with our EMS systems, this is a big deal. The use of hyperosmolar therapy in the operating room for herniating patients. Maintenance of cerebral perfusion pressure over 40 in both the OR and the ICU. Early provision of nutrition and normal ventilation. So avoiding that aggressive hyperventilation in patients who are not herniating. And it doesn't seem to cost us any more to adhere to these guidelines. If you look at hospital costs are about $100,000 overall per child, and that really doesn't increase. This is not statistically significant when we're looking at higher adherence rates. And the ICU costs also, there's really not that much of a difference. And these are pooled data from across 5 sites. So guideline adherence, I would argue, is cost effective. So we said, okay, well, we've shown that adhering to the best evidence is helpful. Let's look at why we're not doing it. And we conducted some surveys and focus groups. We had 19 focus groups at 6 sites, talked to 105 nurses, 56 attendings, included limited English proficiency families to try to get their perspectives, and then really did some thoughtful, meaningful unit and content analyses until we reached thematic saturation. And so here are the factors affecting guideline adherence from the provider perspective. So physicians, nurses, respiratory therapists. The areas that are starred are really important. We're not adhering because we can't get along with each other sometimes. The degree of interdepartmental collaboration and cooperation is a challenge. Having shared expectations in decision making, fostering a culture that values review and use of evidence-based guidelines, and then we need to be trained on how to do it. And I think physicians, there was a lot of reluctance or perceived, questioning of, is this really relevant to my individual patient? This is a question that Dave Adelson brought up earlier. Well, is this really relevant to my patient? They're different this way, they're different that way. But if you talk to families, including 20 LEP families, they'll say, what's really important to us in terms of you being able to provide best evidence care is, can you please talk to each other? Can you teach me how to understand better? And how do we do better care coordination so I can care for my child when I go home? So one of the things that we decided to do in terms of addressing barriers to guideline adherence is really to try to understand what our processes are. So we partnered with our engineering folks and said, okay, let's actually map out what a child goes through when they come to the hospital, to our trauma centers. This is Columbus. And we looked at some very specific, video recorded data, and John Grunner's allowed me to share this, it takes about an hour, 55 minutes, from the time a kid hits the door to the time that the head CT results are actually received. That's an hour. That's a pretty long time. So when we look at Columbus and we say, look, it takes us about 54 minutes for the head CT results to come. And then when we looked at Harborview, if we could scroll down just a little bit, It took us a little bit longer, about 65 minutes or so. So in general, it seems to be that we're taking about an hour for the head CT results to come. And the reason this process is important is because there's so much variability, and trying to understand why we're not adhering to guidelines requires that we understand what the landscape process is. So we use these data to then further understand the relationship between where is the waste time and where are things not happening as they should. Could you go to the next slide, please? Okay, so it looked like, regardless of whether you look at Columbus or Harborview, there are some categories of what we call non-value added time. And in the emergency department, it seems to be that physicians are waiting for results to come back. Now, some of that can be improved and some of that times can't be reduced, but it's about the same at both locations. And then the other area of waiting around is for physicians to show up because we're busy or whatever the reasons are. But from the patient's perspective, that's the area that's the green in the pie chart. And then there are other gaps where things are not happening and it's not clear why. But the reason this is important is because adherence to guidelines currently does not really consider the time that patients actually spend at these different locations. Can we go to the next slide, please? But regardless, the non-value added time is adversely associated with a higher likelihood of poor Glasgow outcome score, making time-sensitive treatments important. Next slide, please. So having realized that guideline adherence is actually important and that there are these barriers to guideline adherence, we wanted to move forward to develop a best practice program to increase guideline adherence at our institution, and I'd like to share some of that with you. Next slide, please. So the PEGASUS program elements at our place consist of the protocols, the perspectives and processes, and a plan. In other words, we really wanted to look at some key performance indicators. We wanted to look at how do we implement and disseminate this education to our nursing staff, reduce barriers to guideline adherence, look at non-value added time, and did this process in a PDSA cycle and look at timeline and metrics across our institution. Next slide, please. The main measures of this pilot project that is still ongoing at our institution include % pathway adoption among potentially eligible patients within the first 24 hours and % guideline adherence achieved in the first 72 hours of admission. Next slide, please. So these are just some preliminary data that I'd like to share with you. So the way we're thinking about this is that you don't always know if a child has severe TBI when they're admitted. When the kids come in, you know, they're tagged as being on the PEGASUS pathway. The nurses decide that they're going to activate this program, and out of the 60 patients who are eligible for the pathway, 56 were initiated and 14 met the original PEGASUS criteria for analysis. Next slide, please. Our nurses actually preferred paper pathways and opted not to use the electronic system. And, you know, as we all know, if the bedside nurses are, you know, have bought into a plan, things work out pretty well. So we actually went against our electronic culture, medical record culture, and said, okay, if you think you can deliver guideline-based care to your patients at the bedside using paper charts, let's do it. So we did this. Next slide, please. And we included, you know, the kids whom you would consider to have severe TBI. And our key performance indicators were, did we start nutrition early? Did we maintain all cerebral perfusion pressures really well? And did we avoid unnecessary hyperventilation in our kids? Next slide, please. We also simultaneously developed a smart anesthesia system for anesthesiologists to provide evidence-based care. Next slide, please. And in the emergency department, developed a rudimentary checklist that the ED nurses could use. Again, they chose paper, where they could check off that they have done the few things that we asked them to do during this pilot, which is take a temperature regularly and initiate fever management early, avoid hyperventilation, measure blood pressures repeatedly, consistently during their stay, and if the child has evidence of intracranial hypertension, initiate hyperosmolar therapy if not contraindicated. Next slide, please. So here are some of our PICU results. As I mentioned, we had 60 patients. about 7 years of age, 69% male, mostly falls, which is consistent with national data. Most of our patients have polytrauma. We had a 93% pathway adoption rate in 24 hours of PICU admission, and we've achieved an 85% guideline adherence rate, which is up from our 69% guideline adherence rate before implementation of our pathway. We made some other observations. You know, some of the patients died early and would have been eligible, but we couldn't deliver the intervention. Some children who were thought to have severe TBI actually turned out to have, you know, an AVM or an aneurysm and were misclassified. And we also importantly noticed that despite best efforts, achieving 100% target to CPP was not possible in all patients. And it wasn't not possible because we didn't try. It was not possible because these kids were too sick. And the nurses did a fantastic job of actually documenting that, you know, we're trying here, we're using different vasoactive agents, we've given our fluids, we've, you know, corrected our volume status, we're just not able to get there. And I think this was very important because it allows us to benchmark what our targets ought to be. Next slide, please. So here are our KPI effects. So as I mentioned earlier, 93% pathway adoption rate. And I said we weren't really able to get CPPs in everybody. This is not statistically significant. The two areas where we made a huge difference is now we're at 100% nutrition delivery within 72 hours of hospital admission. We were doing pretty well beforehand. So, it's not that hard to improve a little bit, but we've achieved that target. Where we've made the biggest gains is in our ventilation strategy. And I think we would all agree that the current thinking is that unnecessary ventilation is bad for the brain because of cerebral ischemia. So we were doing terribly in this area, 12% appropriate ventilation. We're now at 88% on this. Next slide, please. So as I mentioned, we also implemented a pathway in the operating room, and this is an electronic capture system. And what I'm pleased to report is that we have a 76% activation rate. And now not all the kids who have severe TBI are going to go to the OR, but we take care of, a large number of pediatric TBI craniotomies at our center. And not every provider is familiar with the guidelines because A, it varies from the adult guidelines, B, not everybody's as comfortable with kids. And so and even if you are, you may not remember all the 18 things that you're supposed to do. Next slide, please. So what we've been able to show here is that we've improved in our event capture rate. In other words, we weren't really able to detect the hypotension and hypocarbia early on after implementing this electronic system. But after some period of time, this has really improved. And so I think this is another new way to improve guideline adherence. Next slide, please. In the emergency department, we're targeting reducing our CT ordering to, a patient hit the door to knowing what our CT time results are by 10 minutes. We're doing pretty well with hypoxia treated within 30 minutes after onset. And of course, this is a pretty basic metric, but the ED is our most challenging location because it's so very busy. And I think some of the other targets that we're aiming to move towards is looking at blood pressure, hypertonic salient mannitol, and fever control. Next slide, please. So I think this pathway has had some impact on the care that we've delivered at our facility. We're able to show that guideline adherence as a bundled package is overall efficacious. We've achieved high levels of program adoption, particularly in some key areas, and have been able to expand our reach to non-ICU settings as well. We've done some survey satisfactions with nurses and providers, and they really feel supported by use of this pathway. And I think introduction of time measures into the pathway will be important to look at outcomes as well. Next slide, please. The hospital has been really great about partnering with us on this, what started out as a research project. And they've added TBI care to their Access to Excellence dashboard. And I share this with you because I think we're being transparent, trying to educate ourselves and say, look, before we were 69% adherence, look, our goal is, we have target goals. We're actually we have pre and post, we have PICU, look at the gains that we've made here. And then nutrition, we're here, and ventilation, we're here. And I think as we move forward, with our implementation refinement. I shared with you data from 60 patients. We now have data on 78, and I'm pretty sure that we'll have made some additional gains. The summer season it's not quite done here yet, but it's getting there. So we'll have additional data to share. Could we move forward, please? Finally, I just want to make the point that some people think that guideline adherence equates patient safety, and I would argue that it really doesn't. We don't want second insults, and we don't want to harm our patients, obviously, but using guideline adherence as a safety metric itself may not be completely adequate. In other words, this is a nice article looking at advancing the science of patient safety, and it really talks about guideline adherence as a part of that. But if you just measure guideline adherence as yes or no, it doesn't account for the fact that we may have given the wrong doses of things. So I just want to make a distinction between adhering to evidence-based guidelines and patient safety and harm, because they really are complementary, and this is work done out of Hopkins by Peter Pronevost's group. So I hope I've shared with you some broad frameworks for really supporting the concept of evidence-based practice, for guideline development, and for the effort that the Brain Trauma Foundation has put into developing these set of frameworks around how we should be taking care of our kids. I think the next challenge is, how do we actually take this document and translate that to a functional working relationship with our providers, our patients, our families, and so that we can achieve the best outcomes for our kids. Next slide, please. Thank you very much.
Thank you, Monica. That was really great. Dr. Kaplan and I were sitting here chatting of how we want to get our compliance of our guideline up, and it's amazing data you have and amazing evidence that you have that supports that following these guidelines do make a difference, and certainly that's an important factor. I'm going to just kind of, for the sake of time, move ahead, and then we'll end with some more discussion. I'm sure there will be opportunity to discuss these issues as well as some of the others that have come up throughout time.